Well, welcome folks to our description of interoperability barriers and enablers. We're going to be talking about connections, and I certainly welcome this esteemed panel. We have payers, providers, patients, all of us representing different views on the interoperability problem. And for those of you who have been at HIMSS, you know that if we just had more regulation and the perfect standard, interoperability would just happen, right?
That's what I've been saying for years.
Let us raise the issue. What do you see as the real barriers in 2016 to interoperability? Where is it that we can really make a difference?
So largely today, the barriers are not technical. There still are some technical barriers. Largely what we see as barriers are governance and trust, which go hand in hand. I think things like care equality that's promising a trust fabric that can be adopted between many different networks is going to be an enabler to overcoming that barrier.
I think that one of the other barriers that I see working in a state that requires authorization is that as a nation we need to adopt something of a trust from a consent model. Either we're going to do consent or we're not going to do consent. Right now, every state, every local, every facility has a decision they can make as to whether they're going to require patient consent for data information exchange.
And so, of course, the question we want to ask is a private sector organization going to help us rationalize these policies? Does there need to be more regulation? Does there need to be a framework or guideline for governance?
I'll respond to Peter's initial point on trust, and that's certainly been a challenge for us as well. And we've become members of Care Equality and certainly have agreed to those rules of the road. But getting beyond the 4 states, and we operate in over 33 states, those conversations that you talked about, John, 20 people talking to 20 people, a lot of times the first question out of our mouths is, what does the state say? What will the state let us do? And how can we move that information and move it in a safe way?
Yeah, so it's interesting. We're having this conversation around consent and the state regulations, and Surescripts brings an interesting perspective here with our experience in e-prescribing. And if you go back 10 years and look at where e-prescribing was, the regulations in the states, not all states accepted e-prescribing. We had to work with every single state to get them to the point where we could have this national ecosystem of electronic prescribing. And frankly, that's something that we are going to have to do with health information exchange as well.
So there's a lot of options out there. There's a lot of choices. And in order to decide, which technologies are worth it, you have to look at the economies of scale.
And again, when we talk about care quality and the framework, the economies of scale are obvious. You're going to have one framework that you're going to use for everybody. And when you add in other large organizations like a Surescripts, it's one connection, it's one framework, and it levels the playing field, I think, for everybody to move forward, so you can get to the point where you've got meaningful data being exchanged, so you can do the analytics for the metrics to show the benefits.
I expect that we're going to see many record locator services over the next several years, some of them perhaps payer-based, some of them national, like the Surescripts network. Wherever that data naturally lives, if we can expose that to technologies that are searching for a patient's records, so for a payer, or CMS is another great example, they know where the patients who are seen by the most providers, they know where they've been. If we could get that information from them in the form of a record locator service, for example, that would be of huge benefit.
Now, I'm going to ask you guys a very controversial question. Do you think the government is the one to build all of this infrastructure out? Because what we need is digital certificates for every baby at birth. It's going to be great. That's our new healthcare identifier. Is it government? Is it private? Is it both?
The problem is we always try to solve interoperability for the entire nation at once, as opposed to let's go with connect to the community first. Get your community where you're sharing the data and then move on, but it has always been all at once. So I think the private sector said, you know what, doesn't work, we're going to go with the community-based, and now that we've got community-based, we're going to expand with a common framework across those communities, a common infrastructure across those that can connect to each other.
To be successful, we need to take incremental steps. They need to be very meaningful steps, but they need to be incremental. I think where we've gone sideways before is if we try to boil the ocean and do everything for everyone, and really focusing in on some very key use cases, being successful with those use cases, solving the problems for those use cases, and then taking it from there is a good way to move forward.
So I think what we've heard from this great panel, and I want to thank you guys, policy around consent, the need for trust, the need for enabling infrastructure, which includes patient identity, record location, provider directory, rationalize some of the standards, implementation guides, probably not through government, but through the idea of convening bodies that can rapidly bring us to common decisions about what a standard interpretation should be. Now, of course, as was said, we'll never be done, but I hope we leave you with the thought, today, 2016, it's possible, the vendors and the products exist, so go forward and interoperate. No more information blocking. Thanks very much.
Thank you.
Thanks so much.
Well done, sir.